Hello everyone, I am Hande and Atalay from Koç University. Welcome to the first case of November challenge. Today I will present a 44 years old female cancer survivor who presented with a progressive right shoulder pain, a subtle case but with an unexpected twist. Let's take a closer look at her clinical history. The patient is 44 years old woman with a known history of non-metastatic endometrial carcinoma, treated surgically in March 2023. She presented in May 2024 with a progressive right shoulder pain accompanied by mild weakness and movement restriction. Importantly, she reported no redness, swelling, or night pain, which might make an inflammatory or infectious process less likely. On physical examination, her range of motion was limited and painful, but there were no signs of local inflammation. Laboratory findings were unremarkable, so we proceed with imaging, first X-ray, CT, and MRI of the right upper limb. Let's review what those imaging studies revealed, starting with the plain radiograph. On the initial radiograph, there is a lucid lesion extending from the metaphysis to the diaphysis, approximately 7 cm in craniocaudal length. The lesion shows wide zone of transition and there is no obvious central matrix mineralization. There is a mild cortical thinning, as you can see here, but no evidence of pathological fracture. My first question was using the annotation tool, please identify the suspicious abnormality visible on the X-ray, and the lesion was located here, as you can see. On CT, the lesion again visualized. There is a focal cortical discontinuity as in coronal imaging, as you can see here. And importantly, there is no central matrix mineralization, a finding made more evident on CT. There is no obvious soft tissue component extending beyond the bone. And my first question again was the annotation tool. Please identify the suspicious abnormality on the coronal view. And yes, abnormality located here, and this cortical discontinuity. And my second question was, on the CT image, which of the following is the most striking finding? As I said earlier, cortical distraction was the most striking finding here. To better characterize the lesion, particularly its internal structure and soft tissue characteristics, MRI was performed next, and it reveals the same lesion again. Let me show you with this view, with a sagittal one. Yeah, as you may see here, lesion contains multiple cystic areas, and fluid level is better visualized on sagittal view. And the post-contrast image, let me share with you, indicates a solid and septal enhancement, especially in the superior aspect of the lesion. And also, you can see a little bit peripheral enhancement, but no obvious soft tissue extension here also. And on K-trans map and the perfusion image, you can see that lesion is hyperperfused on especially those areas, and the graphics show a type 3 pattern, which indicates a washout and raises suspicion for malignancy. Now, let's look at our first question. What will be the most appropriate next step in management? And for this kind of lesion, the first management was a biopsy. And my second question was, based on the imaging features presented, which of the following is the most likely diagnosis? The correct answer was telangiectatic osteosarcoma. We will review why this is the correct diagnosis in just a moment after one more question. And my last question was, which of the following imaging features best supports a malignant rather than benign cystic lesion in this case? The correct answer was enhancing solid components within the lesion. The presence of enhancing nodules or solid parts strongly raises suspicion for malignant process. I have already revealed final diagnosis. The diagnosis was telangiectatic osteosarcoma. At first glance, it might resemble a benign cystic lesion or maybe metastasis. All three imaging modalities consistently demonstrate an aggressive, purely lytic lesion. Histopathologic analysis confirmed the diagnosis. Now let's take a closer look at key radiologic and clinical features of this rare osteosarcoma subtype and how we can differentiate it from other mimics. To summarize, telangiectatic osteosarcoma is a rare subtype, accounting for about 4% of all osteosarcomas. It mostly affects adolescents and young adults, though older patients can also be affected, like in our case. It typically arises in the metaphysis of long bones, with the distal femur being the most common site, and followed by the tibia and humerus. Histologically, it's characterized by blood-filled cystic spaces with malignant osteoid-producing sarcomatous cells within the septa or solitary areas. So, while it may appear benign at first glance, its biologically is anything but, and early recognition is key. Let's briefly compare it with conventional osteosarcoma. Conventional osteosarcoma typically shows a mixed pattern, which is lytic and mineralized areas, and often displays aggressive periosteal reactions like sunburst appearance and Codman triangle. It frequently extends into the adjacent soft tissue as well. In contrast, telangiectatic osteosarcoma is a purely lytic lesion, often lacking X mineralization and showing multiple fluid levels, especially on MRI. When we focus on the key differential diagnosis in the context of fluid levels, the aneurysmal bone cyst is the main one. While telangiectatic osteosarcoma demonstrates features suggestive of malignancies such as ill-defined margins with cortical destruction, enhancing nodus, thickened septa, and solid components, ABC typically presents soap bubble appearance and well-defined margins. The imaging features of telangiectatic osteosarcoma tend to be more aggressive. This case is a reminder that not all cystic bone lesions are benign. Some, like telangiectatic osteosarcoma, can mimic benign entities such as ABC. Especially when fluid levels dominate the imaging, we need to suspect from telangiectatic osteosarcoma too. And correct diagnosis is critical, because while ABC might be treated with simple curettage, telangiectatic osteosarcoma requires an aggressive approach, usually neoadjuvant chemotherapy followed by wide surgical resection. A misdiagnosis can mean missed opportunity for life-saving treatments. Before finishing, I would also like to share this for those interested in reading more. Thank you very much for your attention. It was a pleasure to present this case as a part of RADGames.